that have to do with the policy challenges that would face the president. And one of those is clearly health concerns, which is the topic of this evening's talk. And to introduce our very special guest speaker, I would like to introduce the provost of the university, June Aprilli. June.
Good evening. The worlds of politics and science are intersecting, some might even say colliding, in loud public debate over issues such as stem cell research, AIDS, abortion, tort reform, uninsured Americans, the soaring costs of health care, prescription drugs, and of course, what to do about all of this. Tonight, we are here together to learn more about the critical choices that must be made for funding, prioritizing, best practices, and policymaking in healthcare and medicine. And I can think of no one more knowledgeable than our speaker, Lewis Sullivan, to address us on this complex topic. Now, Dr. Sullivan is both a visionary and a pragmatist. As a medical practitioner, he has served on the front lines of the medical profession over his entire career, and he is also an academic with public policy experience and a deep understanding of how institutions work, how individuals can shape institutions, and a vision of what can and should be. Born and raised in segregated post-Depression Atlanta during the coming of age of the New Deal and Social Security, he excelled in school and studied to become a doctor. He received his bachelor's magna cum laude from Morehouse College and earned his medical degree cum laude from Boston University. His internship and medical residency were at the New York Hospital, Cornell Medical Center, and then certified in internal medicine and hematology. He taught medicine at Harvard and Seton Hall University Medical Schools before establishing himself in an academic medicine career at Boston University. In the mid-1970s, when his colleagues at Boston University told him, I hear, that he was insane, well, insane for what reason, to walk away from a promising career in an established New England medical center to start a black medical school in Atlanta's inner city. Well, he did just that. He shrugged off the naysayers and went home to Georgia. This is a man, quite obviously, who has some deep personal experience with risk-taking and courageous leadership. In 1975, Dr. Sullivan became the founding dean and director of what would become and is now the Morehouse School of Medicine. The school admitted its first students in 1978. Today, the independent Morehouse School of Medicine has as its mission, I quote, to recruit and train minority and other students as physicians, biomedical scientists, and public health professionals committed to the healthcare needs of the underserved. Morehouse ranks #1 in the nation among U.S. medical schools in the percentage of its graduates who enter primary care practice. 84% of graduates practice in underserved areas. Admission is competitive. Some 2,000 students apply annually for 50 slots in the first-year class. A staunch Republican, Dr. Sullivan left his beloved Morehouse in 1988 to serve as Secretary of Health and Human Services under the first Bush administration. He managed the federal agency responsible for the nation's health, welfare, food and drug safety, medical and medical research. He battled the tobacco industry and championed victims of AIDS. Upon his return to Morehouse in 1994, he took up the office of president, stepping down only recently to become president emeritus. Among his many pursuits and interests today, along with honors too numerous to name and service on many of the nation's leading corporate boards, Dr. Sullivan continues to be in the vanguard of the frontier of medicine. He works to train more black doctors, guide his profession, and to support research that is relevant to the medical needs of those who are underserved. We turn to you now, Dr. Sullivan, to enlighten us about how the nation, and particularly under this administration, how this nation should and could set healthcare policy and priorities. Thank you for coming.
Well, Dean Aprilli, thank you very much for that very generous introduction. And let me begin by saying this, for me, is great experience having this opportunity to visit this beautiful campus and this university about which I've heard about for so many years. And I can certainly assure you that having driven over the campus this afternoon, you do have a very attractive facility. And talking with your students this evening during the reception, I think you also have equally attractive, very bright students. So for me, this is a real treat because I always enjoy talking to young people and hearing about their thoughts, their goals, their aspirations, because I can tell the students here this evening it'll be very few short years that you'll be in positions of responsibility. So your opportunities that you have here to expand your mind, your vision, your base of knowledge is a time to take full advantage because you'll be in positions of responsibility where you won't have the luxury of time that you have today to indeed expand your horizon. So I'm very pleased to be here with all of you. Well, in talking about the future of healthcare in our country, there's no question that this is a very challenging and very complex area. I want to really try and set the stage for my discussion this evening because I first of all want to review with you the strengths of our current system. What is it about a system that of which we're very proud? But secondly, to look at the challenges we confront, or the deficiencies or the problems that we have in our system. Because while we have many things of which we are quite proud, we also have to face up to the fact that there are many things that could be better than they are today. Third, I then want to make some projections for future developments in our healthcare system. How are we going to respond to the challenges that confront us today? And then finally, I want to talk specifically about a commission that I chaired that issued a report last September in Washington at the National Press Club, funded by the Kellogg Foundation, looking at diversity in the health professions, because that's one of the other challenges that we confront as a nation, because we've always been a diverse nation, but over the past 1 or 2 decades, the rate of diversity in our country has rapidly accelerated. Well, what about our current healthcare system? First, without question, we have the strongest health professions education system of any nation in the world. And it was not always that way. But today we have people from all around the globe who come to the United States for training in one or other of the health professions, and training that is often not available in their own country, or training in our country that is considered to be the best available anywhere. We have a strong accreditation system for our health professions programs, whether it's medicine, dentistry, public health, or other. And we have a constant stream of curriculum innovations that challenge our young minds and address areas for new developments in our systems. We also, during the second half of the 20th century, went through a remarkable period of expansion in our health professions education enterprise. And what do I mean by that? Let me go back to the year 1900. In 1900, average life expectancy for Americans was some 47 years. The major diseases that were killing and crippling Americans were such things as pneumonia, tuberculosis, vitamin deficiency diseases, infant mortality, maternal mortality as well. Diseases such as poliomyelitis, smallpox. Smallpox, as you know, has now been eliminated from the world in a marvelous undertaking, multinational enterprise under the auspices of the UN, but with physicians and other scientists living today who participated in that activity. And we are close to eliminating polio from the world. The last case of polio in the Western Hemisphere was 1982 in Peru. since that time, there has not been a single case of polio documented in the Western Hemisphere because of an active vaccination program made possible by the development of polio vaccine during the 50s with the work of Jonas Salk and Albert Sabin. And we have still a few pockets around the globe that do have polio, some in Africa and India and elsewhere. But our scientists are quite optimistic that we, hopefully in just a few years, will be able to say we have eliminated polio from the world as well. Well, as a result of the improvements in our healthcare system and improvements in public health, rather than a life expectancy of 47 years that existed in 1900, life expectancy today for someone born at this time is approaching 79 years. Almost a doubling of life expectancy has occurred in the course of the 20th century. And I mentioned that our educational system was not always the strongest, because certainly in the first part of the 20th century, if you wanted to say that you had gone to a leading medical center for education, the best in the world, it was not the United States. It would be places such as London, Edinburgh, Heidelberg, Bologna. Because in 1900, it did not even require a bachelor's degree to enter medical school. Many students would enter after only a high school diploma. There were very little accreditation standards, and the curriculum in many schools was hardly existent. There are a number of proprietary medical schools owned by physicians or others and run for profit. But that changed in 1910 when Dr. Abraham Flexner released a report that was funded by the Carnegie Foundation that was critical of the then 148 medical schools in the United States and Canada. The Flexner report was very critical of the state of medical education in our country, and that started a cataclysm of events that led to the fact that by 1925, 15 years after the issuance of this report, the number of medical schools had declined from 148 to 80. Accreditation standards were developed. The curriculum recommended by Dr. Flexner in his report of 1910 as a model for medical schools was that of Johns Hopkins, because Johns Hopkins required its students to have at least a high school diploma, but preferably a bachelor's degree. And the medical curriculum at Hopkins consisted first of 2 years of studies in the sciences basic to medicine, thus the basic medical sciences such as anatomy, physiology, biochemistry, etc. 2 years of study there before entering the clinical sciences for study. So that was indeed the model that was adopted because of the influence of the Flexner report funded by the Carnegie Foundation. Well, between 1925 and 1950, the number of medical schools in the country remained fairly stable, around 80. So that in 1950, we were graduating some 8,000 doctors every year from 80 medical schools in the country. But by the 1950s, there were concerns being expressed that without enlarging medical education in the United States, we as a nation would be facing a shortage of doctors. There were reports that were issued. The Coggeshall report, led by Dean Lowell Coggeshall of Yale University, was one report. The Bain report was another, and several others that stimulated action so that beginning in 1956, we saw an unusual period of opening of new medical schools. That began with the Albert Einstein Medical School in the Bronx and Seton Hall Medical School in Jersey City, the first of some 46 new schools that opened between 1956 and 1981. This was stimulated by the availability of federal funds for the development of facilities, for scholarships, for expansion of faculties, development of residencies, and a number of other programs, scholarship support that was quite significant. But then, interestingly enough, by 1977, there were concerns that perhaps we as a nation had overdone this, because we were now admitting and graduating almost 17,000 physicians every year. So then came along the so-called GEMINAC report, or the Graduate Medical Education National Advisory Committee report, led by Dr. Alvin Tarloff, who subsequently became the president of the Kaiser Family Foundation. Well, with the GEMINAC report's issuance, we've then, as a nation, put the brakes on expansion of medical education so that we, since that time, since the late 70s, early 80s, have been admitting and graduating slightly more than 16,000 students from medical schools around the country, and that total of schools went from 80 in 1950 to 126 by the late 80s. We now have, in the last couple of years, have had a couple of new schools that have opened, but they are the first that have opened really in the last 20 years. So we've had expansion of medical education and ratcheting up of the standards for accreditation, so that we have now a number of accrediting bodies that all of you are familiar with, not only in medicine, dentistry, nursing, public health, but also in the various residency programs, graduate programs. So because of all of these programs, it is very clear that we have a very high standard for our educational system, and that's why we can say that we have the strongest educational system for health profession students in the world. But education is not the only thing that is undertaken by health professions institutions. Research is a very important component as well, to develop new knowledge. And here we can again say that we have an outstanding research enterprise in the country. That again is not an accident. Dr. Vannevar Bush was a science advisor to President Roosevelt and Truman, and he recommended in the 40s that we should strengthen the scientific enterprise in our country. And because of his urgings and his influence, the National Institutes of Health were formed. So that today the NIH is the leading research organization in the world, providing some $28 billion annually of research dollars, both for intramural research done on the NIH campus in Bethesda or down in Research Triangle, where one of the institutes is based, but sending most of these $28 billion around the country to medical schools, hospitals, dental, and other health profession schools where the research is done. Well, as a result of this investment, the world recognizes the quality of the research enterprise that has been developed. Because whereas we have only 6% of the world's population here in the United States, throughout the course of the 20th century, half of the Nobel Prizes in physiology or medicine have come to scientists in American laboratories. So the world recognizes the quality of our biomedical research enterprise. And we also have, as part of our research enterprise, the for-profit industry as well. Because that $28 billion of research annually is matched by more than $30 billion of research that is carried out by the pharmaceutical and medical devices industry that translate the basic knowledge that's learned from the NIH-sponsored research into practical new drugs or new therapies. And when a new drug has reached an annual sale worldwide of $1 billion or more, it is then called a blockbuster pharmaceutical. Well, more than 40% of the blockbuster pharmaceuticals have come from American-based pharmaceutical companies. So that's another index of the strength of our system. Let me give you a specific example of the strength of our research enterprise. I went to Washington in early 1989 as Secretary of Health and Human Services, and those of you who are old enough will remember that we as a nation were experiencing an AIDS panic at that time. This was a disease that had been discovered in the early 1980s and was quickly found to be sexually transmitted and was a very frightening disease because there was no therapy. Well, when I went to Washington in early 1989, one of the things I had to confront were a number of AIDS activist organizations who were very concerned about was the government doing enough to try and address this panic. One of the pleasures I had in October of 1989 was approving for the first time reimbursement for the treatment of AIDS with AZT. a drug produced by Burroughs Wellcome Laboratories. That was the first drug shown to be effective. People with a diagnosis at that time would live perhaps 1 or 2, or if they're fortunate, 3 years. Well, fast forward to today, because of our research investments, we now have almost 30 drugs that are effective against the virus, and effective against the virus at various stages in its metabolism, so that now people with the diagnosis of HIV or AIDS, rather than living 12 to 18 or 30 months, are now living 12 to 18 years. Plus they are working, they are raising families, they're earning wages, paying taxes, rather than being immobilized by this virus. And so now many people are starting to look upon this virus under therapy as a chronic disease. We still don't have a cure. And the virus is a very challenging, wily virus that mutates quite frequently, so that scientists are always racing to try and get ahead of the virus, so we're not there yet. But the picture over the last 15 years has changed dramatically. Well, that is a specific example of the power of our scientific enterprise in addressing what was indeed 15 years ago a very frightening condition, in which now people are less concerned about, though we're yet far from a cure. So those are some of the examples of the strength of our system. Strong educationally, strong research, and now let's come to our delivery of health services. We've had, in addition to medicine, dentistry, and nursing, a number of fields that have developed, midwifery, various other allied fields, so that we now have an army or an array of health professionals to provide services to our citizens around the country. We also have a dizzying array of clinical treatment protocols that have been developed for a variety of conditions. Heart disease, we now are seeing a fall in the rate of deaths from heart disease, also a fall in the rate of deaths from cancer. These are small to be sure, but the trends are definitely there, so that now we have some encouragement because of the results of our various treatment protocols that have developed. We also are seeing a growing use of information technology in our healthcare system, because one of the challenges we have is the fact that some 40% of the dollars we spend in our healthcare system are spent on administrative costs. So we have to find ways to reduce those administrative costs, and one of them is by increasing the use of information technology, not only for scheduling patients or delivery of data, but also development of electronic medical record. This will also have the beneficial impact of reducing medical errors, of which we have almost 100,000 such errors that result in severe damage or fatalities among our patients. So these are some of the improvements that we have there. Our public health improvements have been quite dramatic. We take for granted safe drinking water. Well, half of the world's population, or more than half, does not have safe drinking water. They still have waterborne diseases, diarrhea, cholera, etc. But we have a very strong public health system here. We have the availability of nutritious food, and our population is increasingly aware of the role that they must play in enhancing their health by improved nutrition. Maternal and infant care have improved remarkably, as well as availability. Well, during my time as secretary, it was my pleasure to release an updated version of Healthy People, which we called Healthy People 2000, which we released in September of 1990. And Healthy People 2000 was an elaboration or further elaboration of Healthy People. It had some 298 specific health objectives, such as improving immunizations, decreasing infant mortality, decreasing death rates from heart disease, cancer, and a number of other conditions. And with our colleagues in the public health service, as well as those in state health agencies and in the private sector, we have increased the awareness of individuals about the need for their participation in preserving and protecting their own health. And now we have a new iteration, Healthy People 2010. Healthy People 2010 was released in January of 2000 by then Surgeon General David Satcher, and it has grown further, because rather than 298 objectives, it had some 467 objectives here in a whole array of areas. But there were two overarching goals of Healthy People 2010 that were articulated. And the first was to improve the span of healthy, active life for our citizens. And secondly, to eliminate disparities in health status and health care among our increasingly diverse population. So that is our current national goal for health promotion, disease prevention, and I can assure you that come the year 2010, there will be an update or reiteration of this, because it is important to increase the involvement of our citizens in health promotion, disease prevention activities. So we have benefited tremendously from advances in our system. Well, those are the things that we can boast about, but what about the challenges that we have? Well, the first that we hear so much about is the high cost of health care. And there's no question about that, because in 1960, some 5.6% of our nation's gross national product was consumed by our healthcare system, whereas today it is some 15%. It has almost tripled in the percentage of our GNP that the healthcare sector consumes. And mind you, this is during a time where our nation's economy has expanded tremendously. So we have a higher percentage of a much larger economy that our healthcare system is consuming. But in spite of that, we had a robust period of economic expansion during the decade of the 90s. And when I went to Washington, we had 37 million uninsured Americans. Well, today, as you all know, we have 45 million uninsured Americans, and perhaps an equal number who are underinsured, who have insurance, but the insurance is not adequate for significant or major illness. So why is it that during a period of robust economic expansion and growth of the 90s, rather than having the number of uninsured Americans fall, they actually increased? So that's one of the challenges that we confront as a nation. But if you look further at that 45 million people, that lack of insurance is not distributed evenly among the segments of our population. Some 11% of whites lack health insurance, but 21% of African Americans and more than 30% of Hispanic Americans lack health insurance. Think of that, 1 in 3 of our Hispanic brothers and sisters lack health insurance. So that's a challenge that we confront. How do we address that challenge? Of course, the last serious effort to do this was in 1993, in the first early years of the Clinton administration, and we saw then that to be successful in affecting change, you have to develop a broad swath of support throughout society for change, and that didn't happen. I personally believe that it was a strategic mistake to have a, quote, secret committee, because once that occurred, then the concerns developed and suspicions arose as to what this committee was going to do, and that was compounded by the fact that the major health organizations were excluded from membership on this committee. The American Medical Association, the American Hospital Association, the American Pharmaceutical Association, all were excluded. And in addition, they were actually roundly criticized by the administration, and certainly Mrs. Clinton as the leader of that effort in speeches in Baltimore and also in Chicago before the AMA. So whether you agree with these organizations or not, the reality is that they have a lot of power. And that strategy was one which frightened these various segments of our healthcare industry. So what happened? They coalesced and they mobilized to really work against enactment of this plan. And that was one of the factors that contributed to its defeat. Not the only one, but it was a significant factor. Well, one of the other challenges we have with our current system is the fact that there's not adequate diversity among our health professionals in our country. We have an increasingly diverse population, because certainly when I was growing up in Georgia as a child, when you spoke of the minority community, you were really talking about the black community or the African American community. But that's not the case anymore. And as all of you know, our largest minority population today is the Hispanic population, and followed by the African American population, but many other population groups as well, the Native American population, many people from Eastern Europe and from the Indian subcontinent, etc. So that today we have an increasingly diverse population, so that some 25% of Americans today belong to one or other minority group. And our demographers predict that by the year 2050, there will no longer be a majority population. So how do we address that? What does that mean for our healthcare system? Well, this is the question that the Kellogg Foundation indeed decided needed to be examined, and asked me to lead an effort to look at the diversity in our nation's health professions, to state where we are today, and what are some of the things that we should do. And of course, what we reported last September was not surprising, much already known, but there were such things as the fact that although 25% of our population today is represented by one or other minority group, less than 9% of nurses in the United States are members of a minority group, less than 6% of physicians, and only 5.6% of dentists are members of a minority group. You might say, well, why is that important? Well, it's important because medicine certainly is a science-based discipline. And by medicine, I mean broadly, whether it's dentistry, nursing, some of the basic sciences. But this is a scientifically based discipline that is addressed and delivered in a social setting, where effective communication is important, development of trust between the healthcare provider and the patient is important if you are to have patient compliance with recommendations, or the patient returning for follow-up visits. And therefore, if you have a physician who does not speak the language of the patient he or she is serving, that's the first impediment. Or if there are cultural differences between the healthcare provider and the patient, where one inadvertently and unknowingly may cause some tension or distance between the health provider and the patient. Those are the kinds of things that can interfere with that. So having the strongest training in the sciences for an individual who doesn't speak the language or doesn't understand or respect cultural differences can really render that basic scientific knowledge indeed less than sufficient to have a good health outcome. So that is why we must work to increase diversity in the health professions, maintaining the quality of our science and having that continue to grow, but also addressing these other factors that are increasingly important in the delivery of health services to our citizens. Well, what about the future? What does it hold? Well, first of all, we know we will have continued innovation because we have developed a culture that supports that, and we have seen the results of that innovation. Simply the example of HIV/AIDS that I gave, or now the drugs to lower cholesterol, the statin drugs, which didn't exist a couple of decades ago, that is so important. So we know that there are many benefits to be achieved from continued innovation. We will have continued technological advances in the way we approach diseases as well. We have now around the country at any given moment a number of treatment protocols that are underway, some sponsored by NIH, others sponsored by other organizations, including the pharmaceutical industry, to learn how can we best provide therapy for a specific condition. And we're learning that some of the things that we thought we knew before, indeed, were not the best, and we are benefiting from that. We also have a new challenge as a nation. That is the threat of bioterrorism. So how do we guard our citizens against a potential threat of an anthrax bacterium or other bacterial organisms that could be very easily loosed upon our population? So there'll be continued research as to how we will protect our citizens there. The Human Genome Project has been a very exciting, marvelous development, because in June of 1990, while Secretary, I announced the launching of the human genome. And at that time, we predicted that this would be a $3 billion effort over a 15-year period to learn the makeup of the human genome. Well, we now have a very good idea about the human genome, but rather than 15 years, it was done in 10 years. So that by the year 2000, our scientists felt that we had essentially learned the basic outline of our biological structure of our inheritance, and there's now much research underway for us to benefit from this knowledge. We now also have the development of nanotechnology, that is, things on a micro scale that are changing the projections as to how we will address a number of conditions in the future, and that is one of those areas where the promises are indeed startling. And we are an aging society. So we increasingly are confronting the diseases of aging, but we are also, while we're living longer, indeed, it's not only longer lives, but healthier lives, so that we have the benefits of the changes from our system that have resulted in that. But as our present Social Security debate shows us, we now have a Social Security system that doesn't match the demographics of our society today. So one of the benefits of all of these things, better nutrition, better health care, better public advances in public health, all of the benefits of those, now we have other challenges to address. And that's the reason that we are seeing the debate that has been launched about modifying or reforming our Social Security system. Now, efforts to control or restrain demand for health services will continue as a means to try and control costs. We also have efforts to prevent the use of unnecessary or inappropriate care that not only would be inappropriate or not needed, but could also lead to some complications or side effects that could result in people being harmed by this unnecessary care. But with the growth of information technology, that certainly will have a definite effect in reducing medical errors. But the challenge here is to convert our system from a paper system to the paperless system that is underway. And the cost, of course, of initiating that is another challenge. Well, we will continue in the future to have the health promotion, disease prevention effort, because anyone looking seriously at this can tell you that if we can prevent a condition, it is certainly much more cost effective to do that rather than to wait for people to become ill and then try and correct that or treat that. And even if we were able to do that, individuals not always restored to 100% capacity with that. So health promotion, disease prevention efforts will continue. And this means that our citizens must increasingly be partners with our healthcare providers. The day of the omnipotent physician or dentist or nurse is gone. This is the day of a partnership where individuals want second opinions, want to engage in dialogue, want to question the necessity of a test or question the basis for a diagnosis. And I look upon that as a healthy development, because it means individuals are taking more responsibility for their own health, getting involved in this, and indeed, as we succeed with this, that will mean improved health of our citizens. So the current issues with the use of increased electronic systems, we have privacy concerns, which I'm sure we'll be able to address. This will also increase the competence of our health professions because of the fact that aberrant or inappropriate therapy will be more easily ferreted out. And we will continue to have a tug of war between regulation. That is, we want to be sure that we have safeguards in our system to be sure that individuals are not inappropriately treated, but at the same time, we don't want to have a regulatory system that is such a straitjacket that it stifles creativity or innovation. So that will always be a challenge to have the right balance. One of the current problems we are dealing with is the proper balance of Medicaid services between the federal and state governments. And with the pressure on state budgets of the last 4 or 5 years, this is a problem that our nation's governors are increasingly concerned about. And we haven't heard the last of that yet. But I'm convinced that we will succeed in our efforts to increase diversity in the health professions, not only because of the activities of the Sullivan Commission, but many other activities as well. So the hot issues will continue to be such things as Medicare prescription drugs, where we've just learned that the initial projections of some $400 billion during the first 10 years of this law being enacted is going to be closer to almost $800 billion. And of course, the Congress is confronting that issue now, and we will be following this with great interest. But I'm convinced that this bill will stand. There will likely be modifications because of the concerns about costs, but there's such a consensus about the value and need for the prescription drug bill that I'm sure that will prevail. The President has taken a very vigorous stand on tort reform in the system, and almost everyone in the health professions will tell you that this is a welcomed leadership role because of the burden that exists from malpractice suits, but also the cost that this adds to the system as well. Now, health system reform in a broader sense is on the nation's agenda, but because of the current debate about the Social Security system, it's my prediction that we will not have a serious effort for health system reform until we have disposed of the Social Security challenge that is before us now. So what that means, in my view, is that we are a few years away from serious efforts to address reforming our health care system. In the same way that we are engaged militarily in Iraq, which makes it less likely we will become militarily engaged elsewhere. Similarly, on domestic issues, if we're engaged in Social Security, the system will be put into overload if we try and have serious health system reform efforts at the same time, and certainly at a time when significant resources are being drained by our military activities. Some of the complications that exist with our current efforts are reform of the tax code in the country. The debate as to what is the appropriate mix of taxes and who should be paying them, and what the level of taxes should be. But the issues that the business community has been confronting since the Sarbanes-Oxley legislation will be increasingly a challenge for nonprofit organizations as well. Foundations, universities, community organizations, because the accounting demands that have been placed on the corporate community will also be placed on the nonprofit community as well, so that the public will have the assurance that the dollars that are being invested directly or indirectly through their taxes are being appropriately used. So, to sum up, my predictions are continued innovations, new drugs, new devices that will continue to be developed. There'll be certainly the prescription drug benefit will continue, though with some possible modification. I rate the likelihood of Social Security reform almost a toss-up, a 50-50 chance as to whether this will occur, because as you can see, there's not a consensus that has really developed yet on this. Then health system reform, I believe, will not occur in the next few years until we have resolved the Social Security challenge that we have. We will have increased diversity in the health professions because of the broad consensus that is developing that this is something that is not only a question of equity for all of our citizens, but also a question of how do we be sure that our citizens get the best health care possible. And we know that part of that is having professionals who communicate well, who relate well with their patients. So we need to have strong science-based, but also looking at these other communications and cultural issues as well. And finally, all of you will be increasingly involved with your doctor, your dentist, or your nurse, or other health professional in discussing the best options for your care. And that is a good development, because ultimately the best health is really health promotion, disease prevention, or prevention. While we do need to have a strong care system for those conditions that we cannot prevent, there are a number of things that we can prevent that the increasing involvement of our citizens will help to bring that about. So those are my predictions for the future, and I thank you for your attention, and I'll be pleased to respond to questions or comments that you might have.
I think we have a microphone up here, and then we also have one that we can carry around. So just kind of raise your hand, and Dr. Sullivan will identify you and stand up and ask your question.
Yes. Excellent presentation. I appreciate that. In your review of the history of healthcare in this country and how, with all the innovations, there's something that I thought you may have failed to mention in terms of the problems. The role of the federal government's involvement in some of the high cost of healthcare, in terms of with the government involvement in Medicare, that, and also the solution to a problem being more insurance. Doesn't that contribute to some degree to the problem we're faced with today? And asking the government to find a solution may be the wrong approach, and maybe we should be happy with discussing Social Security and not healthcare?
No. Well, that's a good question, because as I mentioned, we are spending a lot more for healthcare, now some 15% of GNP. But at the federal government, 40% of the dollars spent in healthcare are really federal dollars in Medicare, Medicaid, Veterans Care, Department of Defense care issues. But no, I would argue that no, we are better off because of the enactment of Medicare and Medicaid, because services are more readily available than they were before. And also with Social Security, because the incidence of poverty among our seniors has declined dramatically from where it was before the enactment of Social Security. And the health status of our citizens has improved, not simply by Medicare, a number of other things too, but the fact that we really have almost double life expectancy in the last century, and we have eliminated a number of diseases. I think there's no question that we're better off. Now, the real question here that you ask is, can we do this in a way that is less expensive, that doesn't consume so much of our gross national product? And that's a challenge, because there are some who would argue that 15% of GNP is okay if you have a affluent society, because you can wear only one shirt at a time, you can drive only one car at a time, so that if you're spending more on health care and you have results to show for that, then that isn't so bad. But the reality is that the curves of the escalation of costs and the percentage of GNP that this would show really says that within a matter of a few decades we would really be spending all of our GNP on healthcare. So clearly that's not sustainable. I believe that we will have significant effects from the increasing health promotion, disease prevention activities. Because our U.S. Public Health Service estimates, for example, that if we could change the health behavior around the top 10 causes of death in our country today, and these things like heart disease, cancer, stroke, liver disease, kidney disease, and AIDS is among that top. But if we could change that health behavior, and almost every one of these has a component of health behavior, heart disease, our diet, whether or not we exercise, et cetera. They predict that we could reduce premature deaths, that is before the age of 65, by a minimum of 40%. Think of that. Where we have more than 2 million deaths a year in the country, say we could reduce, not all of those, of course, are before the age of 65, but a significant number. If we could reduce that by 40%, and they say maybe as much as 70%, that's remarkable. Chronic disease could be reduced by as much as 2/3. So that if we are able to really educate and motivate our citizens better, we'll have tremendous benefits. So my postulate is that we want to continue to have innovations, because what we can do today that we could not do when I was a medical student is remarkable. We don't want to stop that. But those things are costly. But we have a lot of things that we can change that are also costly by improving health behavior. Smoking, for example, is one of the challenges. 50% of Americans smoked when Luther Terry gave his Surgeon General's report in 1964. Well, now that's down to almost 20%. When I was secretary, it was 25% of Americans smoked. And we know that smoking is the leading cause of preventable death in the country. We are making progress, but you think, really, this has taken us 40 years, in 1964 to 2004, to really go from 50% of our population down to 20% of our population. The question is, why couldn't we do better than that, say over a period of some 40 years in an educated society? So health promotion, disease prevention is easily stated, but difficult to implement. But if we can succeed here, I think we will have increased health status and continue to decrease healthcare costs. Yes?
Sir, I just want your viewpoint on something.
Yes.
My question to you, sir, is in reference to the aging population, and we're all getting to the aging population, how do you see our circumstances in the fact that long-term care should be our focus now? Because acute care, the institutions have that covered, but our long-term care is failing in our community. We have all these people that need long-term care, and we don't have the support of the community to give it. How do you feel that should be our focus now? The government needs to be looking at that, because we're not getting any younger. We're going to get older, and we're going to need that support when we get there.
Well, you're correct. That I agree with you, but I would not really see this as a trade-off, because we still need to have that acute care, and the fact that heart disease now is declining because we have not only the exercise and diet, but the statin drugs, et cetera. So that means that we can eliminate not only I shouldn't say eliminate, but we could reduce markedly a severe condition that also is a costly condition if you have a heart attack and so forth. But you're absolutely correct that we have not devoted the attention or resources to long-term care, and we should, because of the fact that we are getting older. And this I see as a problem or challenge not only for the federal government, but the private sector as well. That we need to see that benefit programs in the private sector also include long-term care as an option. So this is where we really do get into the argument of what is the appropriate amount of our GNP that we should spend on health services. But clearly, services like long-term care that are labor-intensive really tend to be expensive. But one of the advantages or one of the benefits of the longer lives we are living and the fuller lives, it would be one thing if we were living longer, but we were disabled by strokes or heart attacks and so forth. But the fact is, we Americans are living longer and healthier. So these are really productive years, but eventually the string does run out, and we do require various services, including long-term care. I believe that we need to find a way to educate and motivate our citizens at an earlier age that they can really purchase this care at a younger age rather than waiting until they're in their advanced years, when then the cost of doing this is much greater. But it's a difficult challenge as to how we do it. I think there's a question.
One of the things, just to follow up on what you talked about, was just as a statement, is what you see the difference between countries that spend a lot less of their GDP that have as good or better health outcomes than America does, U.S. does, is because they invest heavily in that primary and preventative care on the front end. And along with that, the question I had dealt with your viewpoint on one thing we've seen is even as some health outcomes have gotten better in this country, we haven't seen that gap between minorities and the Caucasian population closing at all. And part of that is because of this access issue you talked about. There is a that many of those minority groups keep losing in ground in terms of access to primary and preventative services. That also impacts, from my perspective, your ability to develop professionals in those minority populations, because they're going to go and treat other minority populations. They have to be able to make a living treating those populations, and if they don't have access to a payment source, that becomes a problem. Locally, we've seen this exacerbated around perinatal care and mental health services in our community. If you're in a crisis situation in both of those areas, what's the solution? And what
In 25 words or less, right? Well, you're quite correct. You know, we have a paradox here in that there's a significant gap in health status between the white population and a minority population. Actually, the paradox is all of us, whether we are majority or minority, are healthier as a population than we were 50 years ago, 100 years ago. But the health of whites has improved to a much greater degree, or more rapidly, than the health of blacks. So we have now a 6 to 8 year gap in life expectancy between whites and blacks on average. But the most extreme gap is white females have a life expectancy of 80 or 81 years, with black males 65 or 66 years. That's a pretty dramatic thing, but as all of you know, there's a gap, whatever race you are, where women are living longer here. So that is a real challenge. And part of the issue of increasing diversity among our health professionals is to help address that because of several things. One, there was a study in the New England Journal of Medicine in 1993, Dr. Miriam Komarami and her colleagues, showing that those communities, those health professionals, doctors, newly minted doctors who were either African American or Hispanic American, were 2 to 3 times more likely to settle in low-income minority populations than white physicians. So she and her colleagues said that this really is a justification for working to increase diversity in the health profession so that these populations will receive care as well. And to increase emphasis on training physicians in the primary care fields as opposed to the specialty fields as well, because what we are confronted with is a challenge of getting basic care for a lot of people. We don't have a shortage of ophthalmologists, someone who needs to have ophthalmic care. That's readily available. But what we have all around the country are communities that don't have a physician, certainly an obstetrical care. I don't know what it's like here in Virginia, but in Georgia, there are places you have to drive 2 hours or more to see an obstetrician. And, if you go into labor, you don't want to have to confront a challenge like that. So clearly, we have the challenge of increased diversity among our health professionals, but also having these primary care fields become more attractive and more rewarding, so that our young health professionals, as they enter the profession, will go into these areas as well. That's an ongoing challenge that really will take a couple of decades to really turn around significantly. Yes.
Dr. Sullivan, those 2 points are really important. And one of the questions I wanted to ask you is, in your School of Medicine, you've been able to attract a high percentage of physicians willing to go into primary care in underserved areas. Do you have certain qualities that you look for in your applicant pool, and could you share that with us?
Sure. Yes, there are a number of things that we do, which I'll tell you about. The bottom line is, it works, but we don't know which part of it or whether it's all. But first of all, yes, we do. Our mission is very clear, so that when applicants apply to us, they are reminded of our mission. And when those who are successful in reaching the interview process, the interview is one where the interviewer tries to assess that candidate's seriousness or level of commitment to going into primary care or into a medically underserved area. We're not perfect, because 16% of our students do go into the specialty area, but the 84% is the highest of any school in the country. Then we emphasize in our curriculum primary care, and when our students have their clinical experiences starting in the second year, and certainly in the third and fourth years, part of that experience is working in a medically underserved community with a physician, so that the student has a chance to see what is it like in this community, both personally in terms of living in a town like this, and professionally. Am I challenged? Is this interesting? Or can I really do this? And what we find is some students come back and say, gee, I never want to do that again. But most of them, and I'd say 9 out of 10 say, gee, that was very interesting. I enjoyed it. So what they do, while they are really forming their opinions, they have the opportunity to live it firsthand and to also talk with physicians in those communities as well. So by the time they graduate, they are really very interested and very convinced about it. And we also try to maintain the idealism that medical students enter school with. We remind our students that medicine is a serving profession, that the fundamental goal of the profession is to be of service to others. And we find that idealism appeals to students. If you have a faculty that believes in it and reinforces it. So all of those things we do. And alumni come back and talk with the students as well. So I think what we've done is develop a culture that reinforces the importance, the challenge, and the excitement of working in a medically underserved community. So that's what we do. Now again, if we were to take some component out, I couldn't tell you what the impact is. We do all of those things, and it works. Yes.
Dr. Sullivan, thank you for your enlightening talk. I really appreciated it. And unfortunately, I think my answer to this question has already been touched on. But I am wondering about the quality of public care. Some people would argue that the quality of public care has gone down or has become harder to maintain with the decreased level of quality nurses, of the increased amount of hospitalists, and I think that increasing diversity in hospitals will help to solve this problem. But a lot of these issues are financial issues, and so I was wondering if you could maybe touch on some solutions to this problem. What some people might argue as a difficulty to maintain the high quality of healthcare that we have in this country today.
Sure. Well, certainly it's a challenge, because what's happened over the last 1.5 decades or so have been increased efforts for cost control that are having an impact. Now, 20 years ago, there was enough flexibility or looseness in the system, that what happened was we had a certain portion of our patient population really paying for their care, but also paying a little extra so that the uncompensated care that was being provided either by the doctor or by the hospital was covered by that. But managed care and other cost control mechanisms have really squeezed that out. And so therefore, there isn't any place to hide there. And again, at Grady Hospital, the major public hospital in Atlanta, now 51% of the patients seen at Grady Hospital, there's no reimbursement for their services. They either no insurance whatsoever, or really inappropriate, health insurance that really is virtually doesn't provide much in the way of coverage. Well, 51% that's a lot to try and cover, and so therefore that's a real challenge to Grady Hospital, and we see in other hospitals an increase in varying amounts that kind of challenge. So that on the one hand, we want our healthcare system to provide care, but the question is, who's going to pay for it? But so far as the quality of care is concerned, I think that in spite of those challenges, and in spite of the fact that we have a growing nursing shortage and an increasing shortage of other health professionals too, that's a real concern that we have. But the data so far show that in spite of the system really being stretched and tight, that by the statistics in terms of deaths in the hospital or misdiagnoses, et cetera, that hasn't happened yet. But that is a concern, because if we put increasing demands on the system but don't provide the resources, then there will come a point, I think, that we will begin to see those kinds of problems. Yes?
If and when we do get around to looking at some kind of broader-based healthcare plan in the United States, I'm sure that people would want to look abroad, but other models there might be. We've all heard about the Canadian model, the British model, the German model, the French model, etc. Do you have a foreign model that you think would be more or less applicable to the United States?
The short answer is no. But let me make this comment. Whereas we don't have a perfect system, and there are a number of things I think we can do to improve health insurance coverage. The fact is that these foreign systems that are frequently advertised as really being very good systems really have some significant flaws. In Canada, in essence, rationing occurs, but it's rationing by the queue lines, so that if it's towards the end of the year and you need a kidney transplant, you might very well find yourself on a queue line that really is quite long. And certainly in England, if you think older than age 55, you're not even put on the queue list. So those are things that those societies have accepted. That's acceptable to them. So that's why I say those foreign models really don't apply to us here, because my prediction is that Americans would not accept that. We think we can do better than that, and I think that we can do better than that. I think we have to really design a system really for Americans that we then have to really thoroughly explain and really have enough vetting of this so that there will be broad public support for this. For example, some of the things that we're looking at are insurance coverage, where I guess the personal savings accounts for health insurance that have been promoted. That's been caught up already in some of the political rhetoric. But the idea there is that if you have a system where an employee is provided by his or her employer, let's say $1,000 for that they pay out of pocket of a first dollar cost, but then you cover that with a catastrophic coverage that picks up costs that start beyond a certain amount. Well, by bringing the patient into the decision making, where you're paying, your dollars for that first coverage, then you are going to be more discriminating in seeing if the care that you're being offered is really necessary or what have you. Also, we have among so many of our citizens, the concept that if you go to the doctor or other health professional, you need a prescription. As you know, if you don't get a prescription, you feel that, well, you haven't really been properly treated. So we have to change that that attitude too, because we're so used to the idea. I mean, the miracle drugs of the 30s and 40s really helped develop a mindset. When sulfa drugs came out in the late 20s and early 30s, they were miracle drugs here, and then penicillin in the early 40s. So we really have developed something of a mindset to really expect that unless we get a pill or something once we go to the doctor, we really haven't been adequately treated. That again is something that better health education of our citizens will really help us address. But that will take time. But I think we are going to really have to develop a system that really will be acceptable to us. The other comment I'd make is this: when I was secretary, frequently I would visit places like Nevada or Phoenix and meet with Canadians who had come south for care because they objected to the system. Now, I believe they were the exceptions. It's my impression that most Canadians accepted their system and didn't question it. But I think that there's sufficient differences in our expectations of the system that it would be hard to have a system like that our own citizens would accept. Yes. I can't hear you. Is that on?
In Richmond, yeah, now it's on. As well as many other communities in the country, the death rate among the African American community exceeds many third world countries. What are the specific things that we should be doing to make the biggest dent in this rate?
Well, there are a number of things here. First of all, childhood immunizations are one of those areas where we fall horribly short of seeing that children get those immunizations against measles and whooping cough, et cetera. Again, thoroughly preventable conditions that would save dollars. Early prenatal care in pregnancy. I visited Japan during my years as secretary, where they have the lowest infant mortality rate in the world. Well, guess what? 98% of pregnant mothers in Japan see an obstetrician during the first trimester of pregnancy. Well, for the United States, that figure is 70% overall. But then you look at various population groups, you find that it's 90 to 95% among Asian Americans, 90% among whites, around 60% among Hispanics, and 40% among African Americans. Well, we know that if a mother comes in for prenatal care early in pregnancy, the likelihood of a favorable outcome from that pregnancy is greatly enhanced. So there are things like that to really have people know that there's a benefit to coming in early, because so often they don't come in because they, quote, are trying to save dollars, waiting until they go into labor, et cetera, and then may really not have a healthy outcome. Also, better nutrition, because again, among poor populations, and this includes blacks and Hispanics and others, the amount of fat in the diet is higher because foods that are high in fat tend to be cheaper foods. We're learning, again, the value of improved diet there. So, and then again, in the black community, we also have a problem of violence. We have to learn how to teach our young people, particularly our young men, better conflict resolution skills. So that's that's a challenge as well. So it's a whole combination of things. Each of them by themselves will make only a small change, but in the aggregate would make a significant difference. But undergirding all of this is the fact that our young people have to really believe in the future, have to have hope for the future, because if you do, then the number of things you'll do to invest in that future. But if a young man, a young woman thinks that really they don't have a future, or really that they have only a few years to live, they'll engage in a number of dysfunctional behaviors or risky behaviors. So all of these things are really part of that. It's a challenge, but again, I'm sure that we can do it, but we have to really be serious about it.
Maybe one word,
Yes.
I'm going to reserve the right for the last question.
All right? Yes.
Particular statements about the state of mental health care.
Oh, yes. Question was, what about the state of mental health care? And one of the things that Surgeon General Satcher did was issue a report on the need for addressing greater attention to mental health care, including insurance coverage for mental health too, because one of the problems with mental illness that the level of insurance coverage there is really much less than it should be, and the restrictions in terms of availability of drugs, et cetera, is also a problem. So again, his report pointed out that we have a lot of benefit from addressing mental health, so that we have people who are functional rather than being dysfunctional and impaired, and the benefit also economically to our society is much greater. But yes, mental health, better mental health coverage is important because, again, we've had a period of stigmatization where people have been unwilling to come forward if indeed there's a problem. So that is a major issue.
I did reserve the last question because I want to ask a different kind of question than maybe has been posed so far. You stated that, and I think quite well, that in the future, medical issues and even more broadly, scientific issues will be much more prominent on the public agenda, even more prominent than they are now. And I think that's going to pose some challenges for physicians and medical professionals to play a bigger role in the public debate and public discourse. And I guess reflecting on your own career, you're one of the rare people who played a very prominent public role as a public servant, but also as a medical professional. What would you say to current people in the medical profession about being involved in public debates? And then what implications are there for educating future doctors to be able to accept that increased role?
Well, excellent question, because clearly my strong feeling is we want young people, whether they're in the health professions or not, to really engage in these public debates and discussions, because ultimately my argument is this is their future that they're helping to develop, and they should really play an active role in helping to shape it. I think that we will be stronger as a society with this public involvement in issues of our young people. The other comment I would make is this. Whereas I think we do have a number of challenges that we confront today in issues such as reimbursement for health costs and malpractice crisis, et cetera. I say that from a scientific perspective, it has never been more exciting or more challenging intellectually as it is today, because of the fact that there's a whole world that has opened up in the health professions since I was a medical student. And there are things that we're doing today that were unthinkable. And so from the standpoint of understanding science and biology and being able to be helpful to patients, I think it's really very exciting and very satisfying. These other issues that we are dealing with, we have to address them, and there'll be difficult debates, but I believe that we are going to address them, so that my statement to young people is really one of optimism for the health professions. But we need to have your voices as young people in finding ways that we address them, because it will be you and your children who will be really benefiting from the solutions, or suffering if we don't make the right decision. So I think having the young people involved in this is very positive, very good for the country, and so I encourage it.
Please join me in thanking Dr. Sullivan. Thank you.